Welcome to Raaonline. So today we are going to see a very important topic, the pulmonary edema. Okay. So as far as pulmonary edema is concerned, it constitutes about 10% of all the intensive care unit admissions. As far as emergency department is concerned, it can go even high up to 15% of what you see in emergency. Patients who come with respiratory issues can have a wheezing or a crackles or a central nervous system cause of this respiratory distress. We'll evaluate how to go through all these things. And if this patient has a pulmonary edema like episode, the hospital mortality itself can rise as high as 25%. Moreover, a 1-year mortality can exceed up to 40% in these individuals. So this pulmonary edema, when you see a patient with pulmonary edema, you need to classify it as either it is cardiogenic or non-cardiogenic. Cardiogenic basically meaning it is increased hydrostatic pressure, and non-cardiogenic is usually increased microvascular permeability causes. We'll see this one by one. So what is the pathophysiology of this pulmonary edema? Normal pulmonary physiology favors a small net influx of fluid from alveolar capillaries into the lung interstitial space. Now let's see, this is one of the alveoli. And next to the alveoli, you will have something called as a capillaries, right? And as we know, the heart is the major organ that pumps blood across the body. So now, there is a pulmonary artery which is originating from the right ventricle, and from the left ventricle, the aorta originates. And there are pulmonary veins here, okay? So, any increase in pressure in the left atrium can be conducted through these pulmonary veins that can even affect your capillaries in the retrograde manner. Meanwhile, the increased pressure in the pulmonary artery can also raise the pressure in your capillaries. Okay, so this is how the pressure increase in your cardiac system can affect the pressure in your lung microvasculature. So, usually there will be two different types of forces acting on any vascular system. One is called as hydrostatic force, and second is called as a oncotic pressure. Okay, so what is the major mechanism of this hydrostatic and oncotic is hydrostatic will try to push the fluid out of the vessel. Okay, hydrostatic will push the fluid out of the vessel, whereas oncotic pressure will try to retain the fluid inside any vessel. So the balance between the pushing out of the fluid and the retaining capacity of that particular system will ensure whether the fluid is passing out of the vasculature or inside the vasculature. Okay, if the hydrostatic force is more, the fluid will pass from the vasculature to outside. When the oncotic pressure inside the vasculature is more, the fluid will be retained more, or there will be influx of fluid. Okay, this is not only for vascular system. Any body cavities of that sort, increase in hydrostatic force will let out the fluid, increase in oncotic pressure will retain or influx of the fluid happens. Okay, as far as this capillaries are concerned, once the pressure increases in the heart, that will cause increase in pressure in the capillaries. So this increase in pressure is called as the hydrostatic force. This will cause leaking of the plasma or the fluid out of the vasculature. And whatever the oncotic molecules, otherwise called as like a magnet inside the vasculature, this kind of oncotic molecules, especially the proteins, will try to retain the fluid. So the difference in this hydrostatic force and oncotic pressure will let us know whether this fluid is going to get retained into the vasculature or is going to get pushed out. In ideal situation, there will be some amount of hydrostatic force which is more than the oncotic pressure. So some amount of vascular leaks will be present. Some amount of fluid will come outside the capillaries. Okay, so this space between the alveolus and the vasculature, this space is called as a interstitial space. Okay, so when the fluid comes to the interstitial spaces, this gets transported to the lymphatic system back into the systemic circulation. Okay, so this is a usual mechanism that happens in the lung microvasculature. Okay, there is a alveoli. Next to the alveoli, there are some capillaries. The hydrostatic force is usually on the higher side because of the heart's pumping capacity. And once there is some fluid which is leaking out of the capillaries into the interstitial septum or interstitial space, you can call it, that particular fluid will go to the lymphatic system into the circulation proper. Okay, so this is the outline of the fluid management in the lungs. Moreover, you will have a question that if this fluid enters into the alveolus, what we call as pulmonary edema ensures. But what is against it is, what is the physiology against it is, this alveoli is covered with some cells which has very tight junctions. Okay, so it's highly impossible for any fluid to pass through these tight junctions and enter into the alveolus. But in certain conditions, if the pressure here in the interstitial space is very high, this alveolar tight junction can be breached and the fluid can enter into the lung alveoli. Okay, so this is what we are going to see in detail. So now coming on to this, understand there is a pipe. Okay, if you want to measure what is the pressure here in this pipe, there's a fluid flowing into this. If you want to measure what is the exact pressure at this point of time, say this is a point A, one way is directly measuring the pressure at this level, right? The other way is you can measure point A pressure at point B when you stop the flow. Okay, because when you stop the flow, the pressure gets equilibrated from one end to the other. Okay, so whatever pressure is at the point B is equivalent to the pressure at the point A. Okay, so this is the mechanism of this. Think that there is a heart here. This is a left atrium. From there, these pulmonary vessels usually drain here. This is a pulmonary veins. Drain here, and these veins are from the capillaries. Okay, and the capillaries, when you trace them, it is just a continuity of your pulmonary artery. Pulmonary artery. Okay, so this pulmonary artery, capillaries and the left atrium are in one single circuit. Okay, the pulmonary artery, the capillaries, the left atrium, these all are in one single circuit. So if at all by any mechanism you can freeze the flow, whatever pressure you measure at LA or the capillaries or the PA is almost going to be the same when you freeze the circulation at that point of time. So what is the mechanism you do that? What is the concept behind it is, you insert something called as a PA catheter. You go into the pulmonary artery, you wedge the pulmonary catheter. So when you wedge the pulmonary catheter, the flow is transiently stopped at that point of time. So enter this pulmonary artery, the capillaries, the left atrium, everything comes into a single circuit like this flow. So whatever pressure you are measuring at this point of time is equivalent to the pressure at the LA, which indirectly tells you the pressure in the capillaries also. Okay, so that is the reason the PA pressures are taken as a surrogate marker of your LA pressures and the capillary pressures as well. So the pulmonary capillary wedge pressure derived from the pulmonary artery catheter balloon wedged into a pulmonary artery segment is just a reflection of left atrial filling pressure and reliable estimate of the hydrostatic pressure of the lung microcirculation. So what we are trying to tell is, in any patient, if you have the PA wedge pressure and it's going to be very high, it indirectly tell you the pressure exerted by the heart on the microvasculature of the lung is very high. Okay, so the hydrostatic force is very high. In the previous slide, we have seen that if the hydrostatic pressure is very high, the fluid tend to move from inside the vasculature to outside the vasculature, which can cause a pulmonary edemic episode. Okay.